As somewhat of a new profession, some people still ask me, what is an exercise physiologist? Well, by definition, an AEP is an allied health professional who specializes in clinical exercise interventions for those with high-risk health conditions or at risk of developing chronic and complex medical conditions. This includes musculoskeletal injury, chronic disease, and many other modifiable health issues. Increasing awareness of the benefit of exercise as medicine in conjunction with an aging population and increasing sedentary behavior has created demand for exercise physiologists. AEPs are recognized as experts in exercise prescription, lifestyle modification, and advocates of healthy living. Exercise and Sports Science Australia, or ESSA, the governing body of practice of exercise physiology. The scope of practice to be discussed provides industry standards whereby the ethical practice, outcomes, and limitations of exercise physiology treatment as determined by ESSA are met to the highest standard to ensure both public and professional approval. The purpose of this presentation is to establish that I in fact have met all standards shown here as set out by ESSA during my professional placement. In doing so, it is anticipated that I, along with other students at Charles State Uni, can confidently employ all skills learned over the course of this degree to a professional standard and will actively able to apply for registration and become an accredited exercise physiologist. In order to do this, I'm going to present to you a number of artifacts and experiences with clients acquired whilst on professional placement and relate them to the ESSA scope of practice. Firstly, I would like to discuss the venue of my clinical placement. Blackfit Clinics is a private company that provide exercise physiology services at a number of locations between Sydney, the Central Coast, and Newcastle. They are leaders in chronic disease management and chronic pain associated with back injuries. Whilst working in this clinic, I have treated a number of clients with one or more long-term health issues, such as cardiovascular disease, musculoskeletal injury, arthritis, obesity, cancer, depression, osteoporosis, chronic fatigue, back and neck pain, occupational injury, chronic respiratory disease, and more. In working alongside a number of established AEPs, I have gained invaluable experience in the applied practice of exercise physiology in a private practice. Blackfit attracts patients from local doctors, surgeons, physiotherapists, allied health practitioners, as well as walk-in private patients. Many of these clients are being treated through enhanced primary care referrals, Department of Veteran Affairs, and as work cover, insurance, injured at work clients. Each client case has proved significantly different and therefore has provided me with a well-rounded and challenging learning environment for myself. The first point on the ESSA scope of practice 2.1, screening, assessing and applying clinical reasoning to ensure the safety and appropriate exercise, which includes the conducting of tests and physiological measures. New patients to Blackfit are required to make a 1-hour appointment for an in-depth consultation with treating AEP. During the consultation, I was required to speak to the patient about their medical history and compile a comprehensive medical history in conjunction with any doctor's reports, MRI scans, x-rays, etc. that the patient has been asking to bring along. Using a Blackfit style SOAP note format, I was expected to detail a case file to be used in the later prescription of exercise. This artifact is an example of pre-exercise screening tool I used whilst on placement. This patient detailed stroke less than 12 months ago with continuing loss of function through the left side in conjunction with occluding sciatica and chronic lower back pain. Patient reports steady blood pressure and cholesterol through medication and has been doing some exercise. The patient has been cleared by the doctor to participate in light to moderate exercise and resistance training, and patient shows motivation to exercise. Whilst on placement, I performed a number of assessments on the patients at this clinic. Set out below are some examples. Range of motion test to assess pain-free range of motion, i.e. shoulder mobility, trunk mobility, hip mobility. Functional movement screen to assess muscle weakness, previous injuries and pain-free range of motion. The functional movement screen intuitively revealed functional deficits such as an inability to balance, coordinate movement or recruit muscles in correct sequence, which is employed to steer exercise prescription. Such exercises were the inline lunge, overhead squat, push-up, prone, unilateral extension. Functional capacity tests were used to assess aerobic capacity or functional ability to perform ADLs. I performed the 6-meter walk test and 30-second sit to stand. This artifact was devised by Backfit Clinics and contained 3 assessments that can be used to determine the level of function of a patient in line with point 2.2 of ESSA Scope of Practice. Functional movement is important as it outlines a balance between mobility and stability along the kinetic chain while performing fundamental patterns with accuracy and efficiency. This requires muscular strength, flexibility, endurance, coordination, balance, which are integral to correct movement and reducing injury, correcting pathologies, improving pain-free range of motion, and quality of life. For the purpose of this example, employed the functional movement screen as the patient was recovering from a lower limb injury sustained whilst at work, and it was suspected that he would score differently for each side. This artifact highlights a functional movement I performed on a patient whilst on practicum. Results indicated significantly less score on the right-hand side of the patient, particularly in lower limbs. This indicates muscle weakness, abnormal recruitment patterns, and may have significant impact on posture and hence the chronic lower back pain the patient was experiencing. The next placement example and artifact I would like to present reflects point 2.3 of the scope, development of safe and effective individualized exercise interventions. I was instructed to revise an exercise prescription for a female patient 66, referred to the clinic due to recently diagnosed hypertension and has a history of chronic lower back pain and schizophrenia, managed well by medication, counseling, and only triggered by stress. This patient asked for assistance with pelvic floor exercises and advice on stretches that won't aggravate chronic lower back pain. I devised a session consisting of 10 minutes of moderate exercise on either the cyclocometer or treadmill, followed by some neutral spine exercises on a gym mat on the floor, focusing on the pelvic floor. These were the isometric pelvic floor contraction, heel slides, and a supine bridge. This patient also reported stress and tightness that was causing her significant discomfort. I prescribed the following static stretching exercises as shown here in Artifact 3.2. Patient advised to maintain neutral spine and correct posture. The goals were to relieve symptoms of tightness and discomfort. A static gastroc, hamstring, pec major, and levitator scapulae stretch were prescribed. After 2 weeks, the client was able to commence some forms of resistance training and reported greater pelvic floor control as a result of this exercise prescription. Point 2.4 of the scope states provision of health education, advice and support to enhance health and well-being. AEPs maintain a role in the education of patients to ensure they can understand the treatment being offered to them. In this instance, the patient asked for more information about a condition he was suffering from and was interested as to whether or not exercise would help him. Artifact 4.1 is an MRI report. A patient brought with them to supervise exercise session. This particular patient wanted to know what is spinal stenosis, what caused the condition, how would the exercise we are doing affect the condition, and would it either increase or decrease pain levels and quality of life. I was able to respond to these questions with some evidence-based information to ensure the client was informed and comfortable in continuing with the exercise prescription. Abnormal changes that cause lumbar canal stenosis are the result of micro instability at the articular surfaces surrounding the canal. Micro instability refers to small abnormal repetitive motion in the joints that lead adjacent vertebra. These movements are clinically silent yet may result in progressive loss of strength in joint capsules and lead to reactive bony and cartilaginous hypertrophy, thickening or calcification of the ligamentum flavum, or subluxation of one vertebra on another, all of which may contribute to narrowing of the lumbar canal and cause constrictive pressure on the cauda-equina nerve root or nerve root complex. This is responsible for his pain. Research shows a comprehensive rehabilitation program of manual therapy, stretching, strengthening exercises for the lumbar spine and hip region have been advocated in professional practice for those with lumbar spine stenosis. The importance of endurance exercises to offset the negative effects of physical inactivity and deconditioning are also an important consideration in the management of this condition. The next clinical example, a female 52, sedentary, prehypertensive and has impaired glucose tolerance, is an example of how I met 2.5 in the scope. This patient is able to manage her IGT and blood pressure through exercise. I prescribed whole body movements that utilize major muscle groups to this patient. Notably, she reported a preference for weight training opposed to aerobic conditioning. The evidence behind resistance exercise and the management of IGT is vast. Skeletal muscle is the primary metabolic target organ for glucose and triglyceride disposal and is an important determinant of resting metabolic rate. The potential consequences of age-related reduction in skeletal muscle mass are diverse, including reduced muscle strength and power, reduced resting metabolic rate, reduced capacity for lipid oxidation, and increased abdominal adiposity. With increased adiposity and aging, the insulin-mediated glucose uptake in skeletal muscle of elderly patients is reduced. The maintenance of a large muscle mass can contribute to the prevention of metabolic risk factor, namely obesity, dyslipidemia, and type 2 diabetes. Artifact 5.1 exhibits how to achieve 2.5 in the S-escape practice. Dynamic movements employing larger muscle groups to increase metabolic rate and promote weight loss. Treadmill warm-up of 5 minutes with RPE of 3 to 4. Cable squat and row, a cable lunge and press, resistance band upright row, resistance band upright reverse flies, step up and overhead press, dumbbell lateral raise, and a cool down on the treadmill. Progression is to promote this intensity of exercises by 5% each fortnight. After 4 weeks, this patient had lost 4 kilos and was reporting increased energy and motivation to exercise as she felt confident she can now exercise correctly. Displayed here a clinical example of a patient I will use to show how to achieve 2.6 in the S-escape of practice. 2.6 outlines the provision of clinical exercise prescription for those with existing chronic and complex medical conditions and injuries. This patient was a male 62 overweight with diagnosed CVD, asthma, chronic lower back pain, right knee osteoarthritis, chronic pain, depression. Low motivation, does report some physical activity. Artifact 6.1 shows an exercise program I devised for a patient suffering with multiple comorbidities and a low functional status. The goal was to increase aerobic conditioning and muscular strength as measured by the 6-meter walk test and 30-second sit to stand. The coexistence of knee osteoarthritis and weakness of the quadriceps group muscles are well known. In patients with knee osteoarthritis, there is a prominent loss in proprioception compared with control subjects of the same age and gender. It has been demonstrated that impaired proprioception adds to the functional insufficiency by generating impairment in walking rhythm, shortening step distance, and a decrease in walking speed and total walking time. Exercise regimes containing repetitive movements increase the ability of the person's control over joint movements in all positions. Evidence-based dynamic stability exercises such as the balance disc prescribed may help to control abnormal joint movement and in turn increase exercise adherence and decrease the severity of comorbidity. Increase in aerobic conditioning and muscular strength were the definitive goals for this client as measured by the 6-meter walk test and 30-second sit to stand. Individual exercises were given for endurance and coordination. This part included a specific exercise intervention that advocates training and the co-contraction of deep abdominal muscles. A recent focus in the physiotherapy management of patients with chronic lower back pain has been the specific training of muscles surrounding the lumbar spine whose primary role is considered to be the provision of dynamic stability and segmental control to the spine. These are the deep abdominal muscles, internal oblique, transverse abdominis, and lumbar multifidus. The importance of the lumbar multifidus muscle regarding its potential to provide dynamic control to the motion segment in its neutral zone is now well acknowledged. It is considered that the role of the deep abdominal muscles acting in co-contraction with the lumbar multifidus is to provide a stiffening effect on the lumbar spine. In addition, there is an increasing evidence these muscles were preferentially affected in the presence of low back pain and lumbar instability. Submaximal training of these stability muscles of the lumbar spine and the integration of training the functional tasks decrease both pain and functional disability in those suffering from mechanical lower back pain or patients recovering from surgery. Throughout these exercises I devised for this patient, the muscle mentioned need to play a stabilizing role and it is anticipated they are actively firing throughout these exercises without exacerbating the surgical procedure. Lastly, in line with the last point of S-escape of practice, it is generally accepted that the private practice AEP clinics such as BackFit are categorized as secondary healthcare. Thank you for listening.